Welcome back to Rad Onc Smart Review GU Cancer Series. This is episode 18, Bladder Mock Oral Trimodality Therapy, Post-Cystectomy Radiation, and Local Recurrence.
Hey everyone, great to be back.
So imagine being told that to save your life, a surgical oncologist must remove your entire bladder, your prostate, and then reconstruct your urinary tract using a piece of your own bowel.
Yeah, that is a massive, life-altering reality for a lot of patients.
It really is. But what if I told you that for the right patient, we could avoid that life-altering surgery entirely just by combining precise radiation and chemotherapy?
Right, but the flip side is, what if you choose the wrong patient for that bladder-preserving approach? I mean, that could literally cost them their life.
Exactly. And that is exactly why today we are putting that selection process to the ultimate test. I will be acting as your examiner today, and my colleague here will be acting as the examinee.
I'm ready for it.
This session is the capstone of our bladder cancer block, and for those of you listening, you, our audience, I want you to treat this exactly like a mock oral board session.
Yeah, absolutely. Do not just passively listen to this one.
Right. When I ask a question, I want you to literally pause the audio and practice answering out loud before you hear our resident answer. Because the goal today is not just to, recite radiation doses from a textbook.
A board examiner wants to hear a very specific, logical flow.
Right. You need to define candidacy first, then frame the multidisciplinary options, give a precise treatment plan, and then finally demonstrate a clear understanding of surveillance and salvage.
And if there is one clinical pearl you take away from this, the overarching theme for this entire block is this. In bladder cancer, selection comes before prescription.
Spot on. Selection comes before prescription. All right, doctor, are you ready?
Yes, let's get into it. Let me organize my thoughts.
Excellent. Let's begin with case 1. We're going to explore muscle-invasive bladder cancer and the strict criteria for trimodality therapy, or TMT, candidacy.
Okay.
You are evaluating a 72-year-old woman who presents to your clinic with a history of gross hematuria. A recent cystoscopy shows a 3 centimeters unifocal tumor located on the left lateral bladder wall. A maximal TURBT was performed, which demonstrates high-grade urothelial carcinoma invading the muscularis propria.
Okay, so muscle is present?
Muscle is definitively present in the specimen, yes. And there's no associated carcinoma in situ, or CIS. A CT of the chest, abdomen, and pelvis shows N00, so no nodal disease, and importantly, no hydronephrosis.
That's a great sign.
Clinically, she has good baseline bladder function, meaning normal capacity and continence, and she states very clearly to you that she wants bladder preservation if that is an oncologically reasonable approach.
Right.
Doctor, how do you manage this patient?
Well, let me organize my answer for the board. The absolute most important first step here is establishing her candidacy for our available curative pathways.
Okay, go on.
Based on the clinical and pathologic facts you just presented, I would evaluate this patient as having CT2N000 muscle-invasive urothelial carcinoma. And honestly, she is an excellent candidate for bladder-preserving trimodality therapy. She has multiple highly favorable features for this approach.
Run through those features for me.
Well, first, it is a solitary, relatively small tumor at 3 centimeters. Second, she has already undergone a maximal TURBT. There is an absence of extensive or multifocal CIS. She has no hydronephrosis on her imaging. And crucially, she has good baseline bladder function.
Okay, so she's a great candidate. But how do you frame that recommendation within the broader context of her options? I mean, do you just walk in and tell her you were going to radiate her?
No, absolutely not. On boards, I would say it this way. While she's an excellent candidate for trimodality therapy, I must explicitly acknowledge the alternative curative pathway, which is radical cystectomy with perioperative systemic therapy, typically neoadjuvant chemotherapy.
Good. You always have to mention the surgical standard.
Yeah. Right. I would present both of these options in a formal multidisciplinary discussion with urology and medical oncology. My final recommendation would be individualized based on her specific medical comorbidities, her personal preferences, and this is key, her ability to comply with the intensive lifelong surveillance required after bladder preservation.
I like that you mentioned the surveillance burden right up front.
Yeah, it's vital.
Yeah.
And if she ultimately chooses bladder preservation, a contemporary standard answer is to proceed with concurrent chemoradiation.
Okay, hold on. Let me stop you right there. If you're listening right now and wondering, wait, if radiation and chemo work so well, why isn't it the standard for everyone?
That is the exact trap the boards want you to fall into.
Exactly. So, doctor, historically, some of our surgical colleagues might view radiation as, frankly, a secondary option. I want you to defend your choice. Why isn't TMT just a fallback for frail patients who cannot tolerate the operating room?
That is a critical distinction. Trimodality therapy is absolutely not just a fallback for frail or medically inoperable patients. For the right patient, a well-selected patient like this 72-year-old woman, it is a legitimate primary curative option.
Okay, but how do you compare the outcomes?
I want to be incredibly careful with my wording here for the examiner. Because there are still no definitive randomized head-to-head trials proving absolute equivalence between radical cystectomy and trimodality therapy, the safest way to express this on the boards is to say that outcomes can be comparable in carefully selected patients.
Comparable in carefully selected patients. Good.
Yeah, I would never state that the two approaches are universally interchangeable for all comers. The strict selection criteria are exactly what make the outcomes comparable. If you loosen those criteria, the radiation outcomes will just look worse.
Let's dig into the biological why behind that selection.
Yeah.
You mentioned she has high-grade urothelial carcinoma. What if the pathology came back differently? Walk me through how variant histologies change your algorithmic thinking here, and specifically why they change it.
The evidence for trimodality therapy is by far the strongest for conventional urothelial carcinoma. If we see variant histologies, we have to adjust our approach because the underlying biology of the tumor is fundamentally different.
Give me an example.
So, for example, if the biopsy showed pure small cell disease of the bladder, we know that is a biologically distinct entity. It behaves much more like small cell lung cancer. It is highly aggressive, it tends to disseminate systemically very early, and therefore usually requires a systemic chemotherapy-driven approach first and foremost.
Good. And what if it is pure adenocarcinoma or squamous cell carcinoma?
Well, if the pathology showed pure adenocarcinoma or pure squamous cell carcinoma, the local biology is entirely different. Squamous cell carcinoma of the bladder, for instance, is often associated with chronic irritation or inflammation, and it tends to be more hypoxic, meaning it lacks the oxygen required for radiation to create the free radicals that damage tumor DNA.
That's the radiobiology key right there.
Exactly. Because of this relative radioresistance, radiation outcomes for pure adeno or squamous are generally poorer, and that pushes the discussion heavily toward radical surgery upfront.
Makes sense. And what about variant urothelial, like micropapillary?
Now, if it is a urothelial tumor with variant differentiation, such as a micropapillary or plasmacytoid variant, it is not an automatic yes or no for radiation. That requires an individualized, highly nuanced, multidisciplinary discussion, often leaning toward surgery if the variant component is aggressive or expensive.
Excellent explanation of the underlying mechanisms. For the listener at home, the resident just perfectly outlined ideal candidacy. But remembering all those specific clinical factors under the pressure of an exam can be tough.
It really can.
Do you have a mnemonic to help the listener lock this ideal patient profile in?
Yes, a highly useful mnemonic to quickly recall ideal candidacy on the fly is SMRT.
Okay, lay it out for us.
S stands for solitary tumor. Unifocal disease is much easier to definitively treat than multifocal disease.
Right.
M is for maximal TURBT. This is crucial because radiation works best on microscopic, well-oxygenated disease. If the urologist can scrape away the bulky hypoxic tumor down to the muscle layer, our radiation is vastly more effective.
Absolutely. What's the A?
A stands for the absence of extensive CIS. Extensive carcinoma in situ implies a field cancerization effect throughout the entire urothelium, meaning the whole bladder lining is unstable. Radiation treats a specific volume. It does not fix a globally unstable bladder lining.
Perfect. And the R?
R is for renal and bladder function being good. We do not want to preserve a bladder that is already contracted, painful, or non-functional.
That would just be cruel. And finally, T.
And T stands for tolerable anatomy. This primarily means no hydronephrosis, which would indicate the tumor is deep enough to block the ureters, and it means the tumor location is amenable to a full endoscopic resection.
Keep that SMART mnemonic in your back pocket, everyone.
Yeah.
Let us move to the next phase of this case. You have effectively counseled the patient, and she agrees to trimodality therapy.
Okay.
However, her pretreatment metabolic panel comes back, and I am throwing you a curveball.
Uh-oh.
Her creatinine clearance is calculated at 45 milliliters per minute. Pick your radiosensitizer and your precise radiation fractionation schedule.
I see the trap there. My immediate concern looking at this lab result is her renal function. Let me organize my answer regarding the systemic therapy first.
Go ahead.
With a creatinine clearance of 45 milliliters per minute, this patient is legally and medically cisplatin ineligible. The cutoff is generally 60 milliliters per minute.
Right.
Therefore, I would explicitly state to the examiner that I would not force cisplatin in this scenario. Doing so would risk severe, potentially irreversible renal toxicity on top of other toxicities like ototoxicity and neuropathy.
Exactly. So what do you use instead to sensitize the tumor?
Given her impaired renal function, I recommend concurrent 5-FU plus mitomycin C. This is the most defensible answer on the boards because it has the clearest, highest level randomized evidence base in bladder preservation, specifically for patients who cannot receive cisplatin.
Let's make sure our listeners understand the how here.
Yeah.
How exactly do 5-FU and mitomycin C work together to make your radiation more effective?
It is a great synergistic combination. So 5-FU, or fluorosil, is an antimetabolite. It essentially masquerades as a normal building block of DNA and RNA, interfering with the enzyme thymidylate synthase.
Right.
This disrupts the cancer cell's ability to synthesize DNA and repair the double-strand breaks that our radiation is causing.
Okay. And the mitomycin?
Mitomycin C, on the other hand, is an alkylating agent that cross-links DNA. What is uniquely fascinating about mitomycin C is that it is preferentially activated in hypoxic environments.
It's key here.
Right, like the oxygen-starved center of a tumor bed that might have been left behind after the TURBT. So while radiation struggles in hypoxia, mitomycin C thrives in it, providing a complementary attack.
I love that breakdown. But, I often see gemcitabine used in the clinic for these patients. Is gemcitabine a wrong answer here?
No, gemcitabine is absolutely a reasonable radiosensitizer in this setting, but there is a major nuance you have to address out loud to avoid a board trap.
What's the nuance?
If I choose gemcitabine, I must specify the exact regimen. I cannot just vaguely say gemcitabine. The regimen associated with the landmark RTOG 071 trial is low dose, twice-weekly gemcitabine, specifically 27 milligrams per square meter.
Right. Because there's another dosing scheme out there.
Exactly. There is also a weekly regimen of 100 milligrams per square meter of gemcitabine, which comes from a completely different earlier bladder preservation experience. The trap is acting like all gemcitabine regimens and doses are interchangeable, which they are not.
No, they are not.
Using the wrong dose concurrently with radiation could cause catastrophic bladder toxicity. But again, to be safest and lean on the largest phase 3 data, 5-FU plus mitomycin C is my preferred answer here.
Excellent point on the gemcitabine dosing and your radiation dose and fractionation.
I will commit to a prescription of 55 gray in 20 fractions to the whole bladder.
For sure. That is 2.75 gray per fraction. To a traditionalist, that might sound like a fringe, highly hypofractionated schedule that risks late toxicity. How do you justify the late toxicity risks to the normal bladder tissue with that regimen?
I would defend it confidently as a strong, contemporary, moderately hypofractionated standard option. It is not a fringe schedule at all.
Defend it.
It is a mainstream bladder preservation schedule with excellent long-term support and data backing it up, particularly from the UK experience in trials like BC 2001 and CHIP.
Okay.
From a radiobiological perspective, bladder cancer appears to have a relatively low alpha-beta ratio, meaning it is quite sensitive to larger daily doses of radiation. And this 20-fraction schedule is highly efficient for the patient, reducing their time on the treatment table by weeks compared to the older standard of 64 gray in 32 fractions, and the long-term data shows the late toxicity profile is highly acceptable and comparable.
Good defense. Let us dig into the evidence you just cited. You selected 5-FU and mitomycin C based on randomized evidence. I assume you were referring to the BC 2001 trial.
Yes.
Tell me exactly what the BC 2001 trial actually proved.
Yes, the BC 2001 trial is the landmark study here. I would be very careful with my wording to avoid overstating the evidence to the examiner.
Why? What did it prove?
BC 2001 supports adding concurrent 5-FU and mitomycin C to radiation because it significantly improved locoregional control compared to radiation alone, and it reduced the rate of invasive locoregional failure, which in turn reduced the need for subsequent salvage cystectomy.
I am going to press you on this. Did it improve overall survival?
That is the critical distinction, and the answer is no. While the long-term disease control curves moved in the right direction more broadly, the key board-safe claim I will make is that it improved local disease control.
Exactly.
I would carefully avoid claiming a definitive overall survival benefit. Overstating that endpoint is a quick way to lose credibility with an examiner. The goal of adding the chemo was to keep the local tumor from coming back and to save the bladder, and it succeeded in that.
Spot on. Listeners, pause and write this down in bold. Do not claim an overall survival benefit for BC 2001. Local control is the name of the game.
Absolutely.
Okay, doctor. The patient completes her 55 gray in 20 fractions with 5 FU and mitomycin C. The radiation is done. How do you assess her response, and what is your specific long-term surveillance plan?
Well, response assessment is fundamentally cystoscopic, not just based on imaging. This is typically done roughly 2 to 3 months after completing therapy.
Who does that?
Urology will go in, evaluate the bladder visually, and perform a biopsy of any suspicious areas or the prior tumor bed to prove there is no microscopic disease left.
Right, and if it's clear.
Assuming she has a complete response with no residual invasive disease, she enters the surveillance phase. My clean schedule for the board examiner is this: rigorous cystoscopy every 3 months for the first 2 years.
Okay, and then?
Then we space it out to every 6 months up to year 5. After year 5, assuming she remains disease-free, it transitions to annually.
And what about cross-sectional imaging?
In addition to the cystoscopies looking at the inside of the bladder, she requires regular cross-sectional imaging, specifically CT scans of the chest, abdomen, and pelvis.
How often?
This is done at regular intervals, typically every 3 to 6 months initially, during those first several years to monitor for regional pelvic nodal recurrence or distant metastatic spread, like to the lungs or liver.
Wow, so this sounds like an incredibly heavy burden for the patient.
It is.
You are asking a 72-year-old woman to undergo an invasive cystoscopy every 90 days before she even starts treatment. How do you frame this quality of life trade-off for her during the initial informed consent?
The quality of life trade-off is the absolute crux of trimodality counseling. I like to frame it using a specific analogy to make the reality clear to the patient.
Let's hear it.
I tell them, it is like keeping a beautiful classic car on the road. With trimodality therapy, you get to preserve the original machinery, your native bladder, and your natural voiding function.
Okay, but what's the catch?
But by keeping that classic car, you are committing to lifelong, meticulous, high-maintenance inspections. Every few months, we have to look under the hood. If the engine ever blows, meaning if you develop a deep, invasive recurrence, the eventual salvage replacement surgery will be far more complex, difficult, and prone to complications than if you had just bought a new car or undergone a primary radical cystectomy up front.
I really like that classic car counseling approach. It perfectly balances the immediate benefit of organ preservation against the reality of the grueling surveillance burden and the heightened complexity of a delayed salvage surgery.
It really helps them visualize the commitment.
It does. We will talk more about the mechanics of that salvage surgery in a later case. For now, let us transition to case 2.
Okay.
While our first patient was an ideal candidate who was able to preserve her bladder, many patients either aren't candidates for preservation or they simply choose to undergo surgery up front to get the tumor out.
Right.
That leads us directly into the postoperative reality, which is where things can get very challenging for us as radiation oncologists.
Yeah.
Imagine a 65-year-old man who took that surgical route.
Let's hear it.
You were consulted on this 65-year-old man. He is status post-radical cystoprostatectomy with a bilateral pelvic lymph node dissection. Prior to his surgery, he received neoadjuvant dose-dense MVAC chemotherapy to try and downstage the disease.
Okay, aggressive up front.
Very. You review his final surgical pathology report, which shows residual YPT4AN1 urothelial carcinoma. The report notes that the tumor directly invades at the prostatic stroma, and 1 out of 18 resected pelvic lymph nodes is positive for disease.
Okay.
The surgical margins are negative. He has been reconstructed with an ileal conduit and currently has a good performance status. Describe this patient's pathology for me and tell me if adjuvant treatment is warranted.
Let me organize my thoughts on his specific pathology because every detail matters here. This is a 65-year-old man with residual IPT4AN1 urothelial carcinoma. The Y prefix is important. It means this is the pathology after he has already received systemic neoadjuvant chemotherapy.
Correct.
So the T4A designation means there is paravesical soft tissue invasion as well as...
Hold on, let me stop you right there.
Yeah.
This is a strict teaching moment and a classic staging trap that catches a lot of residents.
Oh, right.
You just grouped paravesical soft tissue invasion in with the T4A definition. I need you to be absolutely precise with your anatomy. What exactly defines T3 versus T4A in bladder cancer?
Thank you for the correction. Let me restate that perfectly for the board examiner. I must not blur those anatomical lines. Paravesical soft tissue invasion, meaning the tumor has broken through the bladder muscle and is sitting in the fat surrounding the bladder, is strictly a T3 feature.
Yes, that is T3.
Prostatic stromal invasion is a completely different anatomical boundary. When the tumor invades into the stroma of the prostate gland in men or the uterus and vagina in women, that is specifically what escalates the staging to T4A.
Exactly.
So, to accurately describe this patient's pathology, he has residual IPT4AN1 urothelial carcinoma characterized by direct invasion of the prostatic stroma and one positive pelvic lymph node out of a good surgical yield of 18.
Much better. Never blur the lines between T3 and T4 on an oral exam. It shows a lack of anatomical mastery. Now, regarding adjuvant treatment, does this man need it? He just had his bladder removed and had chemo before that.
Yes, adjuvant treatment is absolutely warranted and must be discussed. This patient is at exceptionally high risk for both distant metastatic relapse and local pelvic relapse.
Why so high?
Well, the fact that he has a T4A tumor and a positive node, despite receiving intense neoadjuvant MVAC chemotherapy, means we are dealing with highly aggressive chemo-resistant biology.
Very true. So what do you do?
First, I would recommend discussing adjuvant systemic therapy with medical oncology. Specifically, based on contemporary data from trials like Checkmate 274, I would discuss adjuvant nivolumab, an immunotherapy checkpoint inhibitor, to address his high risk of distant microscopic disease.
Okay, that handles the systemic risk. But what about your domain? What is the role of radiation here? Historically, doing radiation after a cystectomy was viewed as too toxic and largely ineffective. Does PORT, or postoperative radiation therapy, belong in this multidisciplinary discussion today?
Yes, in the modern era, I would definitely discuss selective adjuvant pelvic radiation. I want to frame this carefully for the examiner. Postoperative radiation is not a blanket, routine recommendation for every single cystectomy patient. However, it can and should be considered selectively in patients with PT3B to PT4 disease, node-positive disease, or margin-positive disease to improve pelvic control. This patient with IPT4A1 disease fits that very high locoregional risk profile perfectly. His risk of the tumor growing back in the surgical bed or the remaining lymph nodes is substantial.
You mentioned historically it was viewed as too toxic. What contemporary trial changed your confidence in offering this to patients?
The trial that truly changed this landscape and modernized our approach is the BART trial.
And what is the clean takeaway from the BART trial? If I am the patient sitting across from you, what actual benefit are you claiming to offer me?
The clean takeaway from the BART trial is that adjuvant pelvic radiation improved locoregional control and significantly reduces the rate of pelvic relapse in these selected high-risk patients.
Why does that matter to the patient, though?
Because when the cancer recurs in the pelvis after a cystectomy, it is incredibly painful and difficult to manage, often causing bleeding, nerve pain, or blocking the kidneys. PORT significantly reduces the chance of that happening.
And survival.
Crucially, though, just like with our discussion of BC 2001, I would carefully avoid claiming that PRT provides a proven overall survival benefit. The demonstrable benefit is locoregional recurrence-free survival.
Excellent framing. Listener, if the examiner asks whether postoperative radiation is standard for everyone after cystectomy, you say no. If the examiner asks whether it is reasonable in a IPT4N1 patient, you say yes.
Exactly.
Now, let us get into the technical execution, because this is where the toxicity concerns arise. The patient opts for PORT. What is your exact prescription, and what are your targets?
On boards, I would prescribe 50.4 gray in 28 fractions, which is a standard 1.8 gray per fraction dose for microscopic disease in the pelvis. The delivery technique is critical here. I would mandate either IMRT or VMAT alongside daily image guidance. We cannot use old 3D conformal techniques here.
Why is IMRT so critical? But what exactly are your targets?
Well, IMRT is critical because of what we are targeting and what we are trying to avoid. The target volumes would include the postoperative pelvic nodal basin, specifically covering the bilateral external iliac, internal iliac, and obturator nodes.
And the surgical bed.
Yes. In many modern plans for a T4A patient, I would also include the cystectomy bed, where the bladder and prostate used to be.
Walk me through the anatomy of that postoperative pelvis.
Yeah.
What are the specific clinical pearls or planning challenges that make this so difficult?
The primary conceptual point to grasp is remembering that this is not a bladder preservation plan. There is no bladder left in the pelvis. When the surgeon removes the bladder and prostate, it leaves a massive empty void in the lower pelvis.
Wait.
Think of the postoperative pelvis like a bowl that used to hold a large grapefruit. Once you remove that grapefruit, all the spaghetti on top, the highly mobile small bowel falls down dick into that space.
The grapefruit and spaghetti analogy. I love it.
Yeah, so the major planning challenge is managing and sparing that mobile small bowel that has dropped directly into our target zone. If we give too much dose to that bowel, we risk severe enteritis, chronic diarrhea, or bowel obstruction.
And what about his urinary reconstruction? He has an ileal conduit.
Exactly. I must be extremely careful to protect the ileal conduit, which is a piece of his own bowel used to channel the urine and the stomach on his abdominal wall.
What happens if you don't?
If we give excess radiation dose to the conduit or the stoma, we risk causing a stricture, a fistula, or a complete urinary obstruction, which would require another major surgery to fix. That is why IMRT and daily imaging are mandatory, to sculpt the dose away from these critical structures.
Given how high risk his disease is, would you add concurrent sensitizing chemotherapy to this 50.4 gray plan, just like we did in case 1?
No, I would not routinely add concurrent sensitizing chemotherapy in this postoperative setting. That is a major toxicity multiplier.
Why is it so much worse here?
Combining concurrent chemotherapy with radiation to a pelvis full of mobile small bowel and an ileal conduit could drastically increase gastrointestinal toxicity to an unacceptable level. Systemic therapy, like the adjuvant nivolumab we discussed, is typically handled sequentially in a multidisciplinary fashion rather than reflexively combining it concurrently with pelvic radiation.
Spot on. You have navigated the postoperative high-risk scenario perfectly. You understood the anatomy, the staging trap, and the mechanical reality of the grapefruit and spaghetti in the empty pelvis.
Thank you.
Let us bridge back to our bladder preservation pathway with case 3. We are going to explore the logic of local recurrence.
Ready.
Imagine it's been 2 years since we treated our first patient, but let's change the demographics slightly. You are seeing a 69-year-old man. 2 years ago, he underwent a maximal TURBT, followed by definitive chemoradiation for a CT2N0M0 urothelial carcinoma of the bladder.
Okay, classic TMT case.
Yes, and he had a fantastic complete initial response. He's been on your strict surveillance schedule, dutifully getting his classic car inspected.
Yeah.
Unfortunately, at his 2-year cystoscopy, a new lesion is visualized. A TURBT is performed, and the pathology demonstrates high-grade urothelial carcinoma once again. Dr. Ming, what is your next move?
The most important split in my algorithmic thinking here, the absolute critical fork in the road, is determining the depth of this recurrence. I must explicitly state to the examiner that my management hinges entirely on whether this recurrence is non-muscle invasive or muscle invasive.
Everything flows from that single piece of pathologic data.
Everything.
Walk me through the logic of both pathways. Why does the depth matter so much?
Well, if the pathology confirms that this is a non-muscle invasive recurrence, meaning it is TAC, T1, or CIS, confined to the inner lining or connective tissue, it means the cancer has not penetrated back into the detrusor muscle.
So what does that mean clinically?
In this scenario, a conservative management approach is often still possible. Depending on the exact extent of the new lesion, his prior treatment course, and the overall functional status of the bladder, we can frequently manage this locally. Urology can perform a repeat TURBT to resect it, and follow it with intravesical therapy, such as BCG, which stimulates an immune response inside the bladder.
So he gets to keep his bladder.
Yes, this allows him to keep his bladder, maintaining his quality of life.
And the other path? What if the tumor has grown deep?
If the biopsy proves that this is a muscle-invasive recurrence, the biology has proven itself to be highly aggressive, and we've exhausted our conservative local options. The standard salvage pathway for a muscle-invasive recurrence after prior definitive chemoradiation is a radical cystectomy, provided the patient is medically operable.
We have to remove the organ to save his life.
Exactly.
So, the patient is sitting in your office. He is devastated. He remembers how well the radiation worked the first time, and he remembers how easy it was compared to the prospect of major surgery.
It's a tough conversation.
He asks you, "Doc, can we just re-irradiate the bladder? Just give me another 20 treatments." What do you tell him?
I would try to avoid using an absolute word like never in oncology, as there are always highly experimental or palliative exceptions. But I would firmly and emphatically counsel him that repeat full-course radiation to the bladder is generally not the standard curative salvage approach for a muscle-invasive recurrence.
Why not? Explain the radiobiology to him.
I would explain the concept of tissue tolerance. The bladder, the surrounding rectum, and the small bowel all have a maximum lifetime limit of radiation dose they can safely absorb. When we gave him 55 gray 2 years ago, we used up almost all of that safe allowance.
Right, the dose doesn't just disappear.
No, it doesn't. If we were to re-irradiate the bladder with a full curative dose, the cumulative dose to those normal tissues would be massively overloaded. This risks severe, unacceptable late toxicities. We are talking about causing the bladder to shrink into a painful, contracted, non-functional ball.
Or worse.
Or worse. creating fistulas, which are abnormal connections between the bladder and the bowel, or inducing severe, life-threatening bleeding. The standard and honestly the safest curative salvage approach at this point is surgery.
Since you are sending him to your urology colleague, you need to prepare him for what that surgery actually entails. You mentioned earlier that salvage surgery is more complex.
Yes, significantly.
How do you detail the surgical realities during your counseling without terrifying him, but while remaining completely honest?
I need to be honest with him about the complexity of a salvage cystectomy compared to a primary cystectomy. I explain that while it can absolutely be curative, it is technically much more difficult than if he had the surgery 2 years ago.
Explain why.
The prior radiation causes significant tissue fibrosis, essentially internal scarring. Think of it like burning a bridge. The normal, smooth tissue planes that surgeons use to separate the bladder from the rectum and the pelvic sidewall become welded together.
Welded together, that's a great visual.
Yeah, and because the surgeon has to dissect through this welded fibrotic tissue, the surgery is often bloodier and longer. Consequently, the rates of late surgical complications, such as poor wound healing, anastomotic leaks where the bowel is reconnected, or chronic bowel issues, are somewhat higher.
That is a sobering reality. And what about his urinary diversion options? Does having had prior radiation in the pelvis mean he is guaranteed to wake up with an ileal conduit, a bag on his abdomen?
I would avoid making absolute statements about diversion, as that is ultimately the urologist's domain, but I would set realistic expectations. It is true that an ileal conduit is by far the more common diversion method after high-dose pelvic radiation.
Why is that?
This is because creating an orthotopic neobladder, a new pouch that connects to his native urethra, often requires utilizing irradiated bowel and an irradiated urethra, which have poor blood supply and a high risk of leaking or stricture.
But is it impossible?
No, an orthotopic neobladder diversion can still be possible in very carefully selected patients with excellent tissue quality. I would defer the final technical decision on the diversion type to the operating urologist, but I would ensure the patient understands that an ileal conduit is the most likely and safest outcome.
Outstanding reasoning. You established the critical non-muscle invasive versus muscle invasive fork in the road perfectly, and you didn't sugarcoat the biological realities of re-irradiation or fibrotic tissue planes.
Thank you. It's all about structured counseling.
Now, listeners, we are moving into the final phase of this mock oral. I'm going to initiate a rapid-fire sequence to summarize the core logic of everything we have discussed today. I will challenge the resident to acknowledge the major board traps we've navigated, and then answer a series of clinical questions in just one sentence each.
Okay, I'm ready.
Listener, I want you to literally speak out loud and try to beat the examinee to the punch. First, let us review the 6 major board traps. Doctor, I will list the trap, and I want you to state the rule to avoid it. Trap number 1. Jumping straight to the radiation dose before establishing anything else about the patient.
The rule is that in bladder cancer, the opening answer is almost always about patient selection and defining candidacy first, using criteria like SMART.
Trap number 2. Reflexively prescribing cisplatin for everyone undergoing trimodality therapy.
The rule is you must first rigorously check renal function, hearing, baseline neuropathy, and overall fitness before committing to cisplatin, as it is highly toxic.
Trap number 3. Overstating the BC 2001 trial as a definitive survival advantage.
The safe and accurate statement is that concurrent chemoradiation improved locoregional control and reduced invasive failure, not overall survival.
Trap number 4. Describing PT4A incorrectly when discussing pathology.
The rule relies on strict anatomic boundaries. Invasion of paravesical soft tissue is T3, while direct invasion of the prostatic stroma is T4A.
Trap number 5. Claiming that PORT, postoperative radiation after cystectomy, is either standard for everyone or never used at all.
The correct modern answer is the selective use of postoperative radiation in high-risk patients, like those with node-positive or T3 to T4 disease, to reduce pelvic relapse.
And finally, trap number 6. Making every post-trimodality recurrence an automatic reflex cystectomy.
The rule is you must first distinguish non-muscle invasive recurrence from muscle invasive recurrence to determine if conservative management is still possible.
Excellent. Now for the board blitz. 5 clinical questions, 1 definitive sentence each. Ready?
Ready.
Question 1. A cisplatin-ineligible patient with otherwise favorable CT2N0 disease wants bladder preservation. What is the best supported concurrent regimen to mention?
The best supported concurrent regimen with the highest level randomized evidence is 5-FU plus mitomycin C.
Question 2. Is 55 gray in 20 fractions considered a fringe schedule for bladder preservation?
No, it is a strongly supported, contemporary, moderately hypofractionated standard option.
Question 3. A patient has a high-grade TI recurrence after prior trimodality therapy. Does that automatically mean a salvage cystectomy is required?
No, non-muscle invasive recurrences can often be managed conservatively with repeat TURBT and intravesical therapy in selected patients.
Question 4. A patient has a biopsy-proven muscle-invasive recurrence after prior definitive chemoradiation. What is the standard salvage answer?
The standard salvage answer for a muscle-invasive recurrence is a radical cystectomy if the patient is medically operable.
Question 5. A patient has residual YPT4AN1 disease after neoadjuvant chemotherapy and radical cystectomy. What postoperative conversation should happen?
You should discuss adjuvant nivolumab with medical oncology and discuss selective adjuvant pelvic radiation for local regional risk reduction.
Outstanding job today, doctor. You navigated the clinical logic perfectly.
Thank you. I appreciate the grilling.
I'm going to drop the examiner character slightly to provide a concise recap of the 3 main pillars we covered today for our listeners. Pillar 1. For bladder preservation, selection is everything. You need a maximal TURBT, favorable anatomy, good bladder function, concurrent chemoradiation, and highly disciplined lifelong surveillance.
That classic car maintenance.
Exactly. Pillar 2. For post-cystectomy patients, the modern answer is not just surgery and done. High-risk residual disease should trigger a real multidisciplinary adjuvant discussion, including systemic therapy, and in selected patients, highly precise postoperative pelvic radiation for local regional control.
Right. Watching out for that mobile small bowel.
Pillar 3. For local recurrence after trimodality therapy, the key split is whether the recurrence is non-muscle invasive or muscle invasive. That single pathological distinction drives your entire salvage pathway. If you could say those things calmly and clearly, you will sound like someone who actually understands the biology and management of bladder cancer, rather than someone who just memorized a few dose prescriptions for a test.
It really is about understanding the why behind the what.
It is. Keep that classic car analogy in mind when you counsel your next patient. And always remember the grapefruit and spaghetti when you are drawing your radiation fields in the postoperative pelvis. Before we sign off, I want you to think about the future of our field. With the explosion of targeted immunotherapy and the rapid advancement of circulating tumor DNA, where we can detect a single microscopic cancer cell in a patient's bloodstream long before a tumor ever forms on a scan, will a day soon come when both massive pelvic radiation and radical surgery are considered obsolete for bladder cancer? Will we manage this entirely with molecular medicine? Something for you to mull over as you study. Complete practice oral boards at radoncicsmartlearn.com and subscribe to Rad Onc Smart Review for our next episode. Thanks for tuning in.